ultrasound in evaluation of perineal fistulas. In next few minutes, I'll be discussing about transperineal ultrasound and its role in detection of perineal fistulas. So what is transperineal ultrasound? It is nothing but ultrasound technique used with a high resolution, high frequency probe to put on the perineum, using perineum as a window to evaluate perianal pathology. While it differs from the endoanal ultrasound, wherein the endoanal probe is a 360-degree probe, it is inserted into the anal canal and uses anal mucosa as its window. Here, the perineum acts as the window, hence there is no pain to the patient, while in endoanal ultrasound, anal mucosa may cause discomfort to the patient. While transperineal ultrasound is available in any ultrasound machine, a linear probe which fires in one direction, while 360-degree firing probe is expensive to make and it is very few. Hardly there are about 30 to 40 endoanal machines all over India. So how did I find out about this transperineal ultrasound? One day, it was in May of 2021, a patient came all along from Vijayawada. He came traveling almost 7 hours and he was looking for endoanal ultrasound, and he came to me and he showed me the slip, and when I saw the slip I was disappointed. I have the knowledge, I have the machine, but I am unable to help this patient. So I tried referencing few articles, and then I found out about this article published just in 2019, and it really surprised me because in this particular article it shows that transperineal ultrasound has sensitivity as high as 98%, 98.3%. So that is really very encouraging for me to proceed further. I could immediately learn the technique and apply on that patient, and it was met with a very positive feedback. I was happy to help a couple of thousand more cases over past few years, refining my technique, which I am going to share with you today. I'll be discussing the entire topic under 3 headings. 1, why transperineal ultrasound, the reasons behind it. 2, how to perform a transperineal scan, my technique which I have refined over a period of years. 3, what are the expectations from the transperineal ultrasound, what we can expect and what we cannot expect, that is, what are the limitations of the transperineal ultrasound. Now let's discuss with why. The 3 reasons. The first important reason is its accuracy. This journal of European Journal of Crohn's and Colitis, a very high impact journal with 8.3 rating, published this year, 2025, January, a meta-analysis of various studies done over a period of years regarding the transperineal ultrasound. And what it concluded? Well, it is highly accurate. That is, it is as accurate as 92% in detecting fistulas, 90% in classifying fistulas, and 88% in detecting internal openings. So the next reason why is patient comfort. Unlike endoanal ultrasound, it is an invasive procedure which needs insertion of probe into the anal canal, here transperineal ultrasound, we need not place the probe instead, and we can just glide over the perineum and use the perineal window to find out the perianal pathology. And there are no contraindications whatsoever, unlike MRI. Maybe a patient with a high body mass index of more than 35, no problem. And a patient with who is a child and who needs sedation, no problem for transperineal ultrasound. And any contraindications for MRI, there is no problem whatsoever. You can get, there is no claustrophobia, there is no need for any sedation for any children or any risk factor for pregnant ladies. The third reason why is affordability. Transperineal ultrasound is roughly half the price of an MRI, and it is especially important for unaffordable patient. Next is wide availability. It is almost 50 ultrasound machines to one MR scanner that is been surveyed over 2022 according to AERB. So that is a huge potential and a missed potential for those, especially in patients in remote areas. Then, now we'll proceed with how to perform transperineal scan. I'll be discussing my technique built on simple 3 steps. So ultrasound is nothing but an extension of a clinical examination. So know whatever you know before you go to the scan. So start with a thorough history, present history, past history, operative history, family history, risk factors, diabetes, HIV, everything, whatever it needs to be known, we should find out. And ask the treatment history. Probably he may be undergoing treatment for tuberculosis or underwent treatment for Crohn's previously. We don't know. So review all the previous records and find out the strong why you need to do a scan for this patient. And next comes the clinical examination. This I cannot stress further because performing clinical examination is very vital and it is very comfortable to the patient. You are anyhow examining the patient on the same couch. So I'll be looking for the scars, skin tags, any post-operative operation scars, external openings, and I will correlate with the anal clock. Here, my first job is done to find out the external opening and correlate it with the anal clock. Finally, I do perform a digital rectal examination. This is very vital in finding out the internal openings. A mucosal irregularity anteriorly will eventually find the internal opening anteriorly, and it is very, very important to detect any mucosal irregularity which is widespread, which is very important in detecting perianal cocks. I could detect in very few cases. And performing digital rectal examination is one more important thing. Next, second most important thing is make the patient comfortable. Try to try to look professional, wearing gown, mask, caps, gloves, and try to cover the probe linear transducer with the latex sheath. Then patient preparation, not only physical but mental. Make the patient as comfortable as possible. Take a detailed history and connect with the patient so that before going for the procedure, patient will be fully cooperative to proceed for the examination. So I will examine the patient in 2 positions, dorsal recumbent as well as left lateral position. Then here is my procedure. I will take axial sections by placing my probe horizontally in the anterior perineal region and tilting my probe up and down. This as shown in the small image. By tilting it, I can see the cranial extent as well as the caudal extent. So the finding here is we can see a dark circular band which is clearly depicting the internal sphincter, and surrounding it is the mixed echogenic area representing the external sphincter. Central to it is the submucosal plane, and outside the external sphincter, the hypoechoic area is very important, that is outer sphincteric plane. Then next move on to the sagittal section. I acquire sagittal section by placing the probe parallel to the intergluteal cleft. Then I glide it from right to left. Here I'll acquire the video clips and I use it for the further reference. So taking this sagittal view is very, very important. Sometimes this is the only view that may help in giving the diagnosis. So here we may clearly find out sometimes the anal columns and the zigzag plane that is representing, that can be represented in the dentate line. Here we can differentiate between high anal and low anal fistulas, and we can also sometimes make out any defects in the internal sphincter if they are sent for the sphincter defects. So this is a very, very important view that will differentiate supralevator and infralevator plane, and it will give us the entire extent. And when we cover from the right to left, it will cover the entire ischioanal fossa, anal canal proper, as well as the, it will be able to guide you the internal openings, especially in 12 and 6 o'clock positions. Finally, we'll take coronal sections. Here I'll place the probe perpendicular to the intergluteal cleft, then I'll glide it from anterior posteriorly, that is from the anterior perineal region to posterior perineal region. Here I get similar longitudinal section, but here the anal canal, the internal sphincter will be better appreciated on the lateral aspect, that is 3 and 9 o'clock position we'll be able to better see. Here again the central mucosa and as well as the laterally we can see, this will able to differentiate the right and left pathologies. Next, this how to map pathology over anatomy. We already knew that we take axial sections in reference to the anal clock. So whatever perineal fistulas that start fall into one of the 4 quadrants, either right upper lateral, right lower lateral, left upper lateral, or left lower lateral quadrant. So depending upon the pathology, which quadrant it extends, we will give reference to the anal clock. And then sagittal section, here we will classify the pathologies like abscess and fistulas, supralevator, infralevator. Then from the infralevator plane, again we subdivide into infralevator proper, then ischioanal fossa, then perineal plane. In the coronal, again we try to differentiate the pathology on the right side with the left side. Finally, we come to the what appearances of various pathologies and how to classify them. And now we'll proceed with the abscess part. So abscess, as we all know, appear very dark, and depending upon the location, whether it is in a submucosal plane, it will appear as a hypoechoic area in the submucosal plane, and in the dark intersphincteric plane, that is this in axial section, we can see a hypoechoic area in the lower outer quadrant between the 2 muscles. Then the perianal or ischioanal pathology, wherein we can see the hypoechoic area lobulated with internal echoes extending into the ischioanal fossa. Then this is a abscess wherein intersphincteric abscess is extending into the supralevator plane, forming a supralevator abscess. Next, how to locate internal openings. Internal openings will be looking like a bright speck over the internal sphincter. Remember this point. Bright speck over the internal sphincter represents the internal opening. And here in this axial plane, we can see a bright speck in the 9 o'clock position, and adjacent to it is the hypoechoic area that is representing the intersphincteric abscess. On the longitudinal section, here we can see a bright speck in the internal sphincter that is in the low anal position. We can also measure the internal opening and anal verge distance. Next, what does the pathology look like, or how to divide the fistulas according to the past classification? Intersphincteric fistulas traverse between the both the internal and external sphincter and open outside. So the tract will be close to the internal sphincter. That is, if we find a hypoechoic area on axial section very close to the internal sphincter, that is intersphincteric plane you are talking about. And if we elongate the tract, and we can find out the entire course of the tract extending up to the skin. Next, what can we expect on transsphincteric fistulas, which the tract crosses both the sphincters and exits and reaches the external opening on the skin. So here the external openings will be little away, although I have seen intersphincteric tract openings also opening far away from the anal verge. Here we can say clearly there is a small hyperechoic speck in the internal sphincter representing the internal opening at 12 o'clock position. The tract, a hypoechoic linear irregular area which is extending beyond the internal sphincter as well as the surrounding hyperechoic area external sphincter passing up to the external opening. Next, what will we see on suprasphincteric fistula? The suprasphincteric tract will start with the crypt, go superiorly make a U-turn, and then pass through make an angle and come through the ischioanal fossa. Here, the most important point to learn is if you find any tract making an acute angle at the anorectal junction, most likely, and if you have seen an intersphincteric tract in the axial section, then we are most likely dealing with a suprasphincteric fistula. Extrasphincteric fistula are rare, and you can trace the tract to its origin. The next best way to find out how the tract is to put the probe over the external opening, then trace it back to the anal canal. So that is the easiest way to track any fistula tract. And next, what other findings can we expect on the transperineal ultrasound? Yes, folliculitis. This is a very common condition which mimics external openings of the perineal fistulas. It can be seen as a hypoechoic area not communicating with the anal canal. So sometimes we may see a small hair follicle inside it, and if this is the end of the story that we are diagnosing a folliculitis patient here. Thrombosed hemorrhoids, hypoechoic area adjacent to the anal verge prolapsing from the submucosal plane is definitive of a thrombosed hemorrhoid, and history itself is almost confirmatory there. While sphincter defects, we can see a clear defect in the sphincter of between 11 and 12 o'clock position in the internal sphincter. This we use commonly in the obstetric anal sphincter injuries. Next, what are the limitations of the transperineal ultrasound? So, transperineal ultrasound is best first-line investigation for anorectal sepsis, but it has its own limitations. For example, complex fistulas. It can be challenging initially, and yesterday I did this case which there is multiple openings in this patient, and while performing this scan, I can clearly make out greenish yellow pus coming from the anal canal, and when I did the digital rectal examination, it was very irregular, and the patient gives history of pain in the back, and when I examined, there was a pitting edema on the back. And there were two openings which were at 3 o'clock and one in the left gluteal region. I could give a diagnosis of intersphincteric tract which is extending into the supralevator plane, then entering into the beyond the coccyx, and then it is ascending over up to the lumbar region, paravertebral space. So this was the interesting case yesterday, and this proved the PCR proved to be tuberculosis. History and examination is very, very vital for a transperineal ultrasound. Next, proceeding with this another child who came, 1-year child who came with multiple openings, wherein I gave a report. There were multiple fistulous tracts, intersphincteric fistulous tract, which are extending from the low anal plane, and I strongly suspect the presence of the prawns in this patient. Probably we need to rule it out also. Next, very high BMI patient may sometimes limit the penetration of the ultrasound waves. So we may not be exactly confident enough to diagnose a supralevator pathology or supralevator openings especially. And transperineal ultrasound is highly operator dependent. So we may need experience and expertise in order to give a confident report for this particular scan. So the take-home messages are: why? It is accurate, available and affordable. 2, how to do the scan? Do it in a multidimensional plane. Take thorough history, do thorough clinical examination, digital rectal examination, and take all the sections in axial, sagittal and coronal planes. And what can we expect? Abscesses, fistulas and other perineal conditions like folliculitis, thrombosed hemorrhoids, as well as sphincter defects. I'd like to take any questions now.